Hello, good afternoon, everyone. On behalf of the Department of Bioethics, Christian Medical College, Vellore, Forum for Medical Ethics Society, and the Indian Journal of Medical Ethics, I extend a very warm welcome to you all. Thank you for joining in for the third day of the 10th National Bioethics Conference on the theme of artificial intelligence in healthcare, ethics, law, and human rights matters. We have two sessions lined up for today. We shall start with plenary 3 on the theme called Health, AI, Policies and Governance, Going Beyond Commercial Interest. We close the day with a session 3 on the theme, namely AI and Marginality, Users' Perspectives from transgender persons and people with disabilities. We have eminent speakers today and chairs to engage with on these themes. Most of them have been working at the interface of research, policy, advocacy, and public engagement in their own areas of expertise. I'm here to introduce the theme of the plenary 3 and the chairs before I hand over the floor to the chairs. Let me briefly talk about the session theme. Some of you who were there for the inaugural session, you may recollect that we briefly articulated the relevance of the main theme of the 10th NBC during the inaugural session. We also laid out the themes of the 8 sessions scheduled over the 4 days of the conference, providing brief insights into the rationale behind the choices we made of the session themes. Ethics, legal, and regulatory frameworks, alongside policies and governance structures, go hand in hand in general, and all of us belong to the bioethics spaces. These are very important areas and dimensions of bioethics and the research ethics and clinical ethics areas. And these will be particularly relevant to health AI. In case of health AI, we note two key points here. One is the various unique features of AI, such as their voracious and indiscriminate appetite for data. Many of you would be familiar with these features, especially because we're talking about health AI. It's about clinical and metaclinical data. Some of the most powerful among these cognitive tools are also the most opaque, and these are generally considered black boxes. They often remain intelligible, and their actions are no longer programmed by humans in a linear manner. And their ability to simulate human qualities. So all of these together make the technology very complicated to operate with. And secondly, health AI fall in the category called safety critical AI. And this is because AI systems in these areas are used in applications where human safety is of paramount importance. And secondly, these applications are the consequences of an AI system malfunction can be severe and potentially life-threatening. So some of the examples are, of course, health, of course, the transportation or aviation space, and aerospaces. Some of you who were there for all throughout the conference so far, in plenary 1, we discussed as what can health technology assessment field and scholarship in that area offer us going forward to make health AI safe, affordable, user-centered, and most importantly, are socially relevant, somewhat less topic, but is one of the fundamental ethics principles in research ethics frameworks and discourses. On another note, we witness immense interest of the private players in AI, as well as governments, given the perceived commercial interest in AI technology development and deployment. We also note that there are many documents available on the websites of the Ministry of Electronics and Technology and other relevant ministries of the Government of India. It is extremely challenging to navigate through this set of documents alongside legal and regulatory frameworks and also the AI ethics guidance documents. Commercial interest and international players also require us to have a good understanding of global and local legal and regulatory landscape alongside governance mechanisms, which are currently being discussed and developed, especially around the globe, to ensure that there are oversight systems in place through the pathways of health AI development, deployment, and post-deployment to safeguard users of health AI. Against this backdrop, the intent to curate this plenary has been to help us get insights into local and global conversation relating to legal policy and governance spaces. As said earlier, we have speakers who have long-standing works in these areas. With this, let me introduce the chairs briefly. Many of you would already know them very well. Vivek Diwan, he is coordinator of the Center for Health Equity, Law and Policy, generally called as CHELP. It is situated in Pune. His expertise for over 2 decades has been at the intersections of law, health, and sexuality, with particular focus on HIV, TB, and LGBTQ concerns. He has worked both nationally and internationally on these issues, including leading efforts to change sections 377 of the Indian Penal Code, drafting a bill that became India's HIV/AIDS Act in 2017, building capacity on patent laws and access to medicines, serving as a member of the Secretariat and Technical Advisory Group of the Global Commission on HIV and the Law, and co-authoring the Legal Environment Assessment on TB in India. He has participated as an expert advisor and speaker at various national and international fora and has published widely. He obtained his law degree from NLSIU, Bangalore, and an LLM from Cornell University, USA. Jai Ganesh Uday Shankaran. Jai is the Executive Director of Asia eHealth Information Network. He has over 20 years of experience in planning, procurement, implementation of a wide spectrum of enterprise digital health solutions, including web-based hospital information systems, picture archiving and communication systems, telemedicine, teleeducation, and chronic disease management portals. He's member of several international platforms engaged with digital health, such as Board of Global Digital Network, eHealth Expert Committee of Global South eHealth Observatory, Policy Circle of Transform Health Coalition International Standards Organization Working Group, and Working Group on Telehealth and Virtual Care, and various other. He is an adjunct faculty at the Department of Health Information Management from Manipal Academy of Higher Education, India. He has been a resource person for National Health Information System strengthening and digital health convergence workshops facilitated by Asia eHealth Information Network, together with Ministry of Health and partners in South and Southeast Asian regional countries. He has been a contributor to several publications involving normative frameworks, guidelines, standards, and practice of digital health. And lastly, I would like to mention that unfortunately, we will miss to listen to and engage with Professor Deepika Jain. She has expressed her regrets for not able to join us this afternoon due to medical emergency at her end. We all know that care needs take precedence over every other commitment, and we hope to have another opportunity to learn from her, and we wish that everything will be all right at her end. With this, I invite the chairs to take the floor. Thank you so much.
Thanks, Sunita, and thank you all for attending this, what is going to be hopefully a very, very interesting session. It's a pleasure to be co-chairing with Jay, and a pleasure to be actually introducing the speakers that we have today. Unfortunately, Deepika, as Sunita just mentioned, is not with us, and hopefully we'll get an opportunity to hear her perspectives at some other time. Let me start with Anita Gurumurthy, who will speak first. I'll just introduce her. She's going to give us the first keynote address. We will be hearing from the speakers, and then we will be taking, there'll be a time for question answers and etc., which I believe in the chat, you can place in the chat box, and we will get to them once perspectives are shared. Anita Gurumurthy is a founding member and executive director of IT for Change, where she leads research and advocacy on data and AI governance, platform regulation, and feminist frameworks on digital justice. She serves as an expert on various bodies, including as co-chair of the T20's Digital Transformation Working Group on platform governance, and has been part of the high-level committee of the Net Mundial Plus 10 under Brazil's leadership, the UN Secretary General's 10-member group on technology facilitation, and the Paris Peace Forum's working group on algorithmic governance. Anita is also a board member of global justice organizations such as the ETC Group and university centers such as the Tech and Policy Lab at the University of Western Australia and International Development and Social Change Program of Loughborough University. Anita contributes regularly to academic and media spaces, and it's great to have you here, Anita. We've intersected at some point earlier a few years ago, I recall. Anita's keynote is going to be on health AI policies and governance discourse. Have we got it right? So without further ado, I hand over to Anita for her keynote.
Thank you very much. It's a pleasure and honor to be here. And I'm sure this is one of those conversations that we are going to be having for the next decade at least, because as this powerful phenomenon of datafication in the world unfolds, we will see that questions of politics and ethics are the key. They're the key, and they are actually something that ought to be given center stage. So without ado, I'll just start my presentation slides. I hope the slide deck is visible.
Yeah.
Yeah. All right. Thank you. So I am going to start with some truisms and not, of course, take your time, because scholars and practitioners in this group are really aware that we are talking about a public system that is actually the backbone of what everybody calls our digital future. We cannot ignore the fact that people and their right to health is at the heart of any future, digital or otherwise. I think we note with considerable concern expenditure on domestic health, the percentage share of that in the budget, and how it is really a minuscule number, in absolute terms and also relatively speaking. We're talking about just a sixth of the global average of 6.5% at 1.1% of India's GDP in 2021. The density of physicians, number of people who are medical professionals available to 10,000 population, is estimated to be 7.3, which is in the largest populated, country in the world, is really falling much below the global average of 17.2. We actually have to juxtapose this with some of our policy rhetoric. The policy rhetoric has increasingly turned technocratic, partly also because the global narrative and the halo around technology has been moving in that direction. But also because India also sees itself in geopolitical terms as a leader in the technology space. This basically means that there is a significant push for AI, not only because science and technology become important instruments for geopolitical control, but also because the business of science and technology is very important for geoeconomics. So this we know very well from a long-standing debate on access to medicines, and why we must really hold the line of ethics as preponderant, right? So in relation to the debate on technology and AI, technology, data, and AI, and the platform economy as such, where everything is becoming platform, I think we really have to understand that there is closely tied to the geopolitics of this, the question of economics. And the idea of digital transformation in healthcare is tied to the healthcare industry, maybe a misnomer, because we don't really know whether the industry cares very much about people's health, but we certainly know that it cares about intellectual property. And of course, AI-powered innovations are really at the cutting edge of what is getting patented, with very aggressive strategies, preemptive patenting, etc. And this means that not just clinical data, but even allied data, for instance, in the blue economy, for instance, looking really at new pillars of medicine, right? You're looking at longevity, for instance, and all of this is leading to investments in ocean research, which is tied to health research, which is tied to datafication, tied to the pharma industry. So all of this is really to say that when we are talking about patient care and optimizing resource allocation and all of that, suddenly we find that 40 years or 50 years of the health movement in India, and certainly about 30 long years of people's right to health, we find that the person and people are really missing from ideas of decision-making processes in the technocratization of health. So a recent report from Center for Internet and Society actually captures this in some way. They actually look at the data supply chain and auditability of the data supply chain in healthcare and AI. Of course, this is really important because who owns the data, who is making use of the data, and who is actually able to innovate on the basis of the data. These are separate questions, and they're all questions of power. And they're questions really of tremendous relevance also because I did mention intellectual property. I also want to mention that in the world of data, it's not just the ability to generate data that matters, but it's the ability to convert data into meaningful insight that really counts for innovation. And so what the research report talks about is we are seeing about 5 to 6 critical areas, right? Image-based diagnosis, which is increasingly becoming more and more important. Apollo Hospitals, for instance, leads the way in this. Medical procedures, consultation chatbots, drug discovery, automated surgeries, and disease surveillance. Of course, it's worthwhile asking which of this is really benefiting the public health system. And I think that will require us to set the bar for public health research really high, because much of this information also is privatized. In the olden days, at least, it was possible to trace the money, so to speak, but increasingly with data, somewhat enclosed in the guise of intellectual property into trade secrets, right? Trade secrets, basically that it's a contract between one hospital chain and another laboratory situated somewhere in Boston. What really happens is that nobody else really knows, what are these innovations, what is the probability of innovation, and what plausibility exists for other researchers with public interest research pursuits to actually access this data. This simply means, and this has been translating in the past, I would say 15 to 20 years in many, many areas. And permit me to use an analogy here, which has nothing to do with public health care and delivery systems, which is a sector of public transportation. It should be logical that the private data generated by the platform companies, which is, let's say, Uber and Ola, is available to the municipality or to the city corporation in order for it to actually plan its transportation and vehicular movement. This is very logical because it's the data that is coming from people, people's privately owned vehicles, transactions among people. And this data is actually the city's data. But the narrative around this data is already in the form of privately generated information that is held in these intellectual property enclosures. And many of these models, therefore, are inaccessible for public policy. Therefore, it's actually a dependence that gets created for local governments on external vendors. Now, to move out of this example and extend this analogy of the transportation sector to the health sector, what's really happening is that health information, not just public health information about open data sets or government data or data held by the government, but an entirety of information ecosystems which are pertaining to considerations of public interest and public health are all being privatized. And this creates an external dependence on vendors to develop AI models, which means that, rather than develop priorities that may pertain to the country, which may actually be in the realm of, let's say, breakthroughs in tuberculosis, or breakthroughs in treating malaria, or breakthroughs in treating child malnutrition. We will actually be pursuing agendas that are set elsewhere because there is profits to be gained from researching certain forms of futuristic. How can I look? When I'm 60, how can I look 20? Right. So this is the kind of questions that are being posed by AI. In AI modeling. So this idea that we can actually emulate from existing sets, prioritization for the global south is something that has to be challenged from the get-go. But where do we begin is actually the question. And before I move to the case study, I'm going to present to you of the ABDM. I really want to say that academics who are working in the health and AI space are really, of course, very, very concerned, partly because of the AI systems, which create certain benchmarks about who is an average person, who is an average human being. And these actually then are extrapolated into generalized models, which may really not apply at all. My presentation, however, is not necessarily going to focus very much on understanding of bias discrimination and how it multiplies in AI. Personally, I believe that that is something that all of us understand, that if the data is not representative, and if you actually have data sets in training models that are not representative, then you're obviously going to get AI models that are in the business of prediction, and that are not only in the business of prediction, that are superseding medical acumen of physical human beings. And that is really dangerous. And I think that this is an understanding that all of us have, and this is something that is uncontestable. But what I would like to do is really focus a little bit on something slightly different. I'm going to talk about the base architecture of AI, which is the world of data. And here I'm going to really talk about Ayushman Bharat Digital Mission, which is a data infrastructure, which is ostensibly designed to make the wealth of India's health data available for realizing the common good for better public health. The stated objective is this, and of course, it really takes a public to keep public health data systems accountable and true to their vision. So we will examine how the Ayushman Bharat Digital Mission is faring on this. And why do I focus on data? I focus on data not only to look at questions of misrecognition that might pertain to bias in data sets, but I'm looking for deeper issues of inequality and injustice that are tied to the AI economy in particular. So the AI economy is a large industry, and we must understand it in that way rather than really just reduce AI to one model that may be available in an MRI machine. We are not really looking at AI that is transposed as a gadget here and there, but we're looking at the entirety of the AI economy in which particular logics of data really operate. So we start with the Ayushman Bharat Digital Mission's stated objective, which is to develop the backbone necessary to support the integrated digital health infrastructure of the country. What we actually see is that the policies that were developed also by the Niti Aayog during the COVID pandemic were, of course, they were critiqued in the public domain very, very heavily for being completely ahistorical. I mean, it almost seemed like there were solutions in search of problems, because we really had this magic thing called AI. We had this magic idea called digital technologies. So the bridging of the gap is not even between citizens and citizens, right? Those citizens who are the advantaged citizens who have access to private care or access to really escape the tyranny of the absence of good public health care. But we're actually talking about stakeholders. So the minute you enter into the technology realm, you will find, and it's good to know these things because sometimes we sit in these drawing rooms and we have to have conversations with big industry walas. And it's good to understand that stakeholderism is a big thing in the technology space. And if some of you in the audience are also technologists, you would really know that we're talking constantly about some digital highways, and all of these, the imaginaries are very much in the ether, right? Because essentially there is a certain reification, almost as if all of this is transcendental and they're not rooted in the material realities of inequality, poverty, and lack of dignity for most people. So the vision has been technocratic. The vision is to enable the frictionless exchange of health data in order to incentivize private sector health innovation to address the country's public health challenges. So what I'm going to do is to really unpack this, and I want to draw your attention to the idea of health innovation. This is a country where, for a long, long time, it all seems like, amnesia. But basically, we've even talked about barefoot frontline workers, right? There have been movements in different parts of the country where people have really tried to see how the last mile can really be bridged for greater accessibility, greater equity in healthcare. But the idea of health innovation in all the policy documents with respect to data and AI, and this is not really because India wants to be technocratic. Maybe the only silver lining in this entire thing is that the discourse around the world for all developing countries around AI policies is more or less like this. And I can say this with a fair degree of confidence because my organization has been in the business of tracking these policies. So if we were to feel slightly assuaged just because our neighbors and everybody else is also thinking as technocratically, we need to actually understand that this ahistorical representation of what is innovation is really at the heart of why ideas of innovation are never grounded when we think about AI systems. So the ABDM's infrastructure for data exchange. So the whole idea is there is data everywhere. So the premise is there's so much data. That data has to be, somehow harnessed for a particular imaginary of innovation. So we need certain tools to make that data flow. These data have to flow in value chains, preferably outside the country, so that the global north can tell us, how to innovate. So the first thing is the digital health ID. The second thing is health facility registry and health professionals registry. The third is unified health interface, very, very important because the rest of the presentation will focus on that, which is a set of open protocols for interoperability, right? So data comes from, let's say, electronic health records, right? They come from one hospital, they come from another hospital, and the entire anxiety for the technological community is how do you make this data talk to each other, right? So when the data comes, there has to be standardization. So there can be seamless data exchange for an AI model, which then will be able to crunch all the numbers and project all the predictions. So all this data, as was pointed out initially by the session anchor, is not just clinical data, but it's also many other kinds of data. So it's data about hospitals, pharmacies, wellness centers, insurers, et cetera, et cetera, et cetera. And finally, of course, the digital health application, so that on your mobile phone, you can have yet another one of those platforms and apps. And you can manage your so-called consent framework through your mobile phone. This may be slightly for the techies in the group or people who are enthusiasts who understand how the data flows in these data systems. But basically, there is the data principle in our DPDP, that is the data protection law, India's data protection law. The idea of the data holder is the data principle, who holds the unique health ID. And via the consent manager, right, the patient can consent to the sharing of their health data with health information providers and health information users. So it can be your doctor, or it can be health information users like an insurance agent, etc. The third is there are health registries, and these registries are facilities or they can be professionals who effectively carve out who the actors are within the digital health ecosystem. So these are people who are really trying to interface between the data and the laboratory, right? So these are the health registries. So that these are the people who actually know what exists where, how do you procure the data, and how do you actually act in a way that the digital health data market functions in a seamless and smooth way. And the Ayushman Bharat digital system has a system architecture. Again, this is for the techies. So there's an innovation layer. And of course, an obsession with all technologies because technologists, because without standardization, without a one-size-fits-all solution, which is, of course, antithetical to personalized healthcare or a universal right to health, you can never have a one-size-fits-all. But the idea of technology is quite antithetical to this, right? Unless you had an Aadhaar, you cannot really which is a set of digits, right? Which is a number system. So everyone is reduced to so many digits, right? So unless you do that, you can really not operate a technology data system. You can, of course, operate a digital system because even telemedicine exists, right? It's a content platform. But if you're actually managing the AI system, you need data, and to have data, you need a certain standardization, a kind of a lowest common denominator, so that supports what may be called particular AI models. So the state provides the essentials. This is the way it's imagined. It's this is something that comes repeatedly, whether it's health, agriculture, education. You see the same design. The state provides the essentials through the development of standards and protocols, and the private entities in the domain are invited to provide the services, right? There is really not much of a talk about how the public research system, the public scientific establishment, and public interest and participation of the public can be deepened and enhanced through any of this. It's a silence that's very loud in its absence. So I'm going to obviously draw attention here to something that all of you are very, very familiar with, which is the bio. People who've been in a career of looking really closely at public health ethics is about these four pillars, which is autonomy, beneficence, non-maleficence, and distributive justice. So we really need to do one very important thing, which is to run the ABDM, Ayushman Bharat Digital Mission, through each of these principles. So first is do no harm. So the data ecosystem of ABDM lacks an effective data governance framework. Why is that? Because neither the Digital Personal Data Protection Act, the DPDP, nor the Health Data Management Policy, right? We do not actually have a specialized, debated, which means debated in Parliament, law for health data. We don't have it, but we do have a health data management policy. But neither of this has any particular mention of use and reuse of anonymized data. That is, if you give consent once for the management of your data, the fact that you cannot withhold its reuse for subsequent uses that you may find malified is really not a right that you enjoy. So, for instance, if I, as a public interest minded individual, want to contribute my data for public health research only, then there is no means that I can actually specify this. So there are many, many questions that arise because of this problem, which is what about risks of predatory downstream data practices, right? Someone might de-anonymize, someone might do a group profiling. And group profiling risks are everywhere. We do understand that. This can pertain to religious minorities, it can pertain to gender minorities, it can pertain to sexual minorities. So who's responsible for a data breach is not at all there. Now, this is very interesting. So the essentials are provided by the state and the innovation is provided by the private sector, but neither is liable. Without adequate recognition of special protection for sensitive personal data, let's remember that the DPDP does not have a definition of sensitive personal data. And this actually means that you really cannot ensure non-malfeasance, right? There is, in the world, when you look at all AI publications, very reluctantly or otherwise, because at least it's fashionable to say so, people will say do no harm, because the first thing in the Bible of AI ethics is do no harm. But, if you really take that and unpack, the way in which we are traveling in our imaginations of data governance, we're really not incorporating do no harm. And finally, this entire data blind consent manager platform for data exchange, right? Somehow data will come in, and you saw all of those diagrams, which have been imported from government websites. This idea that it's completely technical and it will be seamless. And in fact, it actually says that we are neutral to all data because we're data blind. The idea is to ostensibly say, we don't care whether the data is from a poor Dalit person or it is from a rich person. That kind of assertion is actually quite scary, because many times in the practice of health, you might actually lend your innovation to the sensitivities of context, right? And so you, for instance, maternal health, right? You really need to know particularly with sensitive personal information, whether somebody is pregnant before you prescribe something to them. So what are the guardrails to ensure in a context with low literacy, low digital fluency, how patient consent can be fair, free, and informed? So all of these things we really need to think through. The second principle is autonomy and the ability to make choices. And a lot can be said about the way autonomy is conceived. I mean, autonomy for us, all of us who use mobile phones, is simply to look at all those copious pages of terms of services from all the platforms to say yes, yes to cookies, yes to everything. Because, without that, you cannot avail of any of these digital services, right? They're all monopolies. They're private monopolies. So also in the healthcare domain today, we see that the ABDM data architecture is more or less coercive, right? And we also hear, and we see on the website of ABDM that there are plans to integrate Aadhaar with the health ID. So it's a kind of interoperability that is not backed by law, but it is there. The idea is there. Now, the flagship insurance scheme, Prime Minister's JAY, requires registration with India's foundational ID Aadhaar. This actually means that for many that need insurance, and of course, all of us in this economy of healthcare, we do need insurance. The PMJAY website does not permit registration using any other government ID. So you're seeing a state push towards establishing Aadhaar as a foundational identity layer upon which health services will be provided. So it's a data fee. So whether or not you like it, you provide your data as a fee. And if you don't provide it, no service. So you're locked out, which certainly does not only undermine your individual and collective autonomy, it certainly takes away your right to health, right? So this is really quite scary in many ways, because people who struggle with disabilities, people who struggle with authentication, biometrics, people who are stigmatized and don't want to give their biometrics or want to give their biometrics in as few places as possible, all of them are going to be denied the right to equitable access to healthcare. And the grassroots research that we have in this is people with social stigma, such as HIV/AIDS patients, really tend to be excluded en masse for digital ecosystems, severely diluting their patient autonomy. The other way to argue about this is also that if they don't have their data represented adequately in these data sets, how are we going to make models that are sensitive to the enormous diversity that we need to actually account for in our healthcare systems? The third bioethics principle is beneficence, which is to promote well-being. Patient centricity is seen as critical in the ABDM vision, but it does not materialize in practice. The idea of patient centricity is a kind of idea of a commercial visibility, right? You are central to the data system, so congratulations, now you're visible to the market. Someone will approach you through one of those spam calls so that they can sell insurance to you. So we actually interviewed a bunch of doctors in the course of our research, and they expressed concerns about the electronic medical record standardization requirements, which basically means that you have a pull-down menu and you have to record within that your diagnosis of patient data or your diagnosis of the patient's disease, which basically means that there is a likelihood that you may not be able to accurately put down things. And this impedes accurate and precise clinical data reporting, which is so vital for patient care. So where is the well-being? And finally, distributive justice. I think sometimes on some of the health lists, e-lists that I'm part of, I see very, very provocative and extremely important and timely discussions. And I really wonder what we can do to make this more and more popular, this kind of information, because we're talking about the health insurance industry and the way in which the government is really underwriting this industry by putting people out there and the data of people out there. And what we're actually seeing is, given the poor state of healthcare infrastructure, health insurance becomes a mode to direct private investment towards geographies where there are very, very, very few providers. Even so, we are actually seeing through research that those are not the places where investment is going from private clinics or private hospitals. So even though government is seeking to incentivize private health providers to go, most patients end up in the cities, in the hubs, in the towns, right? So this kind of effort to underwrite private capital is really not working for redistributive efforts. Now, with Aadhaar seeded beneficiary databases of ABDM, there is a gold mine. Now, this gold mine will allow access to different data sets through the Universal Health Interface. You remember I spoke to you about the UHI, which is that programming interface, which is going to enable data to be readable, right? Machine readability of data is critical for AI model builders. So this is going to come. And as I already said, the vision of ABDM is to make private market research, count on public data. So this is where we are with respect to where things are going. So I'm just going to conclude with a set of thoughts and won't take too much time. I think the trajectory that we see is that health datafication is accelerating the marketization of healthcare. So when we talk about AI, we're really not talking about models that are foundational models that will enable us to solve big problems. So we're not building models necessarily, except in pockets through the tireless efforts, I would say, of certain people in public health and public interest research in the country who may want to build models that are very contextual. So this marketization of healthcare, making access and affordability contingent on data, right? So your access and your affordability depend on two kinds of datafication. One is the state mandates that you get integrated to data. Otherwise, you opt out of the service, right? The second is commercial database profiling will decide whether you are worthy of insurance, what is the interest you will pay through insurance, which is, of course, very unethical, right? I mean, this is a very old problem. It's not a new problem. So who has a right even to be insured is something, that is really not, it's not even about health ethics, right? It's industry ethics. Even the insurance industry is based on ethics of certain probity, right? So database profiling allows you to completely even, put down the veil of this kind of ethics that used to exist in the market. This is likely to disembed public healthcare provisioning from its moorings in the citizen social contract. So what is the state doing? Why is it providing health? Is there even an instrumental, can we even associate instrumentalities with the right to health? Or is the right to health, deontological, right? Is it available to all of us just because we are part of society? These questions become important philosophically and ethically. And the current trajectories of health data and AI innovation are on a pathway that will benefit market capitalization and private value creation at the expense of the public good of universal healthcare. So it's not just that we are dealing with marketization. I mean, I wouldn't stop my inference there. I would actually say that you're eroding public value. So I would actually suggest that in the tech debate, architecture is policy. So if you design something, because we cannot reduce technology to the banality of some experiments that the market is conducting today, we must elevate technology to our vision and aspiration of a better tomorrow, right? I mean, we have to rescue data and AI models from what really erodes the public to something that promotes public interest, public value, and public health, right? And so our architectural design and planning need to shape society in a particular way so that, the built environment of technology is different, right? So that's very important. And these choices, of technologists, and more, I think health activists need to penetrate these so-called citadels of technology design. And, we've had the pleasure and privilege of interacting with many doctors who are, geeky, they like to build, they like to play with these. And, it's wonderful to have conversations with them to deepen our own understanding of rights-based ethics. And assumptions about tech and innovation are at the heart of social adoption of technology, right? What is an innovation? I think that question of what is an innovation is really, really important. And it's an old question. And in the AI economy, of course, there is, you often hear the data has to be open, Data has to be interoperable. AI models have to be scalable. I think it's really important to take one step back and say, why? Why must everything be open to everyone, right? I mean, is there something inherently beneficial about public data being taken into enclosures of a large private laboratory, which has the capacity and the capability to process it into AI models? Just the availability of data doesn't create capabilities, right? So then shouldn't certain data be available primarily for public health research? So this idea of openness, interoperability, and everything on scale has to be somehow, grounded to certain hard questions, which only the people can ask. That's really important. And I really want us, therefore, in relation to AI, to think about three things. And I would share on the chat as soon as I'm done. This is my last slide. A link to doing diversity, equality, and inclusion correctly in AI models. So if some of you are interested in AI model building, this idea of systemic rights, but it of course doesn't pertain, the publication doesn't pertain to the right to health. But I think we need to think about three non-negotiable rights in relation to AI models, data and AI models: the right to inclusion, the right to participation, the right to dignity. So we need to look at the structures through which a certain geoeconomic and geopolitical order is being perpetuated. And I don't have to say much about the battles that we have lost during the COVID pandemic, when internationally, even the richest countries refused to give public licenses for certain drugs. It was a sobering moment when we actually realized that even countries in the European Union, that used to be talking about the European values, were not willing to part with a penny, right? So how do you remedy systemic disadvantage? How do you redress the democratic deficit, not listening to people's voices? And how do you reverse misrecognition? These would be the primary questions for any research, I think, on the right to health for all in relation to data and AI models. I'll stop here. Thank you.
Thanks a lot, Anita. That is very, very thought-provoking. I have a question or two myself, but I think there are a couple of others. But before that, let me turn to Jay, my co-chair. I think it would be good if Jay had some thoughts also, having worked on data. We do not have, I don't believe that the other speaker has actually been able to join. And so we have a little bit of time. Oh, Barry is here, actually. I
Yes,
see
Vivek
Barry.
Barry has come in.
Oh, excellent. So, Jay, over to you to introduce Barry, and then we can proceed with questions after Barry concludes.
Thank you, Vivek. I have the pleasure to introduce Dr. Barry Suleiman. Dr. Barry Suleiman is the Associate Dean for Academic Affairs and is an assistant professor specializing in healthcare law at HPKU Law, Qatar. He is also an adjunct assistant professor of medical ethics in clinical medicine at Weill Cornell Medicine, Qatar, where he serves as the co-director of the Intersection of Law and Medicine Conference Series. He holds a PhD in law from the University of Cambridge and is a fellow of Harvard Medical School's Center for Bioethics. He was formerly editor-in-chief for both Cambridge International Law Journal and Medicine and Law. He is a co-editor of the research handbook on health, AI, and law, which is a leading book in the field. He has published in leading journals on the regulation of AI in healthcare and was the lead principal investigator for a grant at HBKU that created guidelines for the development of AI in healthcare research. His work on AI has received the National Science and Sustainability Award from the British Council in Qatar. And it's my pleasure to invite Dr. Barry Suleiman to be our keynote speaker, the second keynote speaker for the day. Thank you. Over to you.
Thank you so much. Can you hear me okay?
Yes.
Great, great. And you can see the slides okay?
Yes.
Fantastic.
If you could
fantastic.
maximize it, yeah.
Easier, fine, great. Well, thank you all so much for having me. I'm very grateful indeed. Perhaps what I can do is give you an oversight and insight into the legal developments that have arisen in this area. There's research into this space really began. The first articles that really looked at governance of AI in healthcare started quite far back in 2014. Back in 2014, there were only like 1 or 2 people looking into this. And about 6 years ago, there was probably 5 to 10 legal scholars really looking at this. And it was around then that I conceived of this book, the Research Handbook on Health, AI, and the Law, bringing together those scholars and some of the emerging scholars that are coming through in the field. It's an open access book. I put the QR code on the screen there so that you can access it. This resource, we hope, will frame the field. It came out last July. It's already had about 25,000 downloads. So it's becoming quite, I think, a helpful reference point. But I want to go even beyond the book and give you a broader insight into sort of the lawyer's eyes into this area and how we got where we are today. And so to do that first, I think it's helpful to understand something else I've written about, which I call the AI to law framework, which is how did we get to the hard laws that we have today from the increased use of AI in healthcare. So if we go back to those scholars, so 5-10 years ago, they were noticing that AI was being looked at by some hospitals for use in medical practice. And they also noticed that this was posing some new challenges that hadn't arisen before. And these are quite familiar now when people discuss it. But back then, it was sort of a new issue to deal with. So, for example, the adaptive nature of algorithms, they learn as they go. The existing legal systems that had been developed would approve of medical devices to go to market based on fixed algorithms, but they didn't really deal with adaptive algorithms. And the legal system only really dealt with certain scope of medical devices. It didn't deal with broader legal issues of the use of AI in healthcare that we worry about, especially in medicine. So they started examining this and asking, well, can we adapt existing laws to deal with these problems? And so the answer was, yes, we can adapt these laws, but only up to a certain point. And after that point, we're going to have to change those laws to deal with these challenges. And that primarily looked at the area of tort law, so injury law, and still there are inquiries looking into that area. At the same time, what happened was the development of soft law, and we've seen this proliferate around the world in recent years. All of these guidelines you see coming out of the OECD, the World Health Organization, out of the European Union, various entities. There are now hundreds of these guidelines. And as I wrote in this article that I'm referencing on the screen here with the QR code, I sort of think there are so many of these codes that they're practically meaningless. And one really has to think about, well, what are these codes doing in practice? But nevertheless, a lot of these codes have arisen. Some of them are useful, and they have helped to plug that gap in law that scholars have been assessing until new hard laws came along. And so now we are at the end of that stage, which is the new law stage and the development of new laws. And that is the most pertinent example is the Artificial Intelligence Act. But there was also other ones that were proposed. There was the Artificial Intelligence Liability Directive that came out of the EU, but that's been scrapped. There's the revised Product Liability Directive. There have been changes to medical device regulations so that they consider also AI elements to devices. But overall, there's still a long way to go in the new law phase, the hard law phase. So that's sort of the overview of what's been happening. And in the book, we sort of try to examine, well, what are the key legal issues that these legal systems don't really deal with, that they need to deal with? And we look at different applications of the use of AI in healthcare. So we look at how is AI used for administrative purposes in hospitals. So for example, it's used for determining bed allocation on wards. It's used for determining flow on emergency wards. It can be used in facial recognition, cybersecurity elements, in robotics, like robotic surgery. There are many, many use cases that have been published about at length now. But what we sought to do was just to look at a few of these use cases to identify what are the legal issues that come up. And time and again, it was similar legal issues that arose. It was concerns about medical device regulations, data security, discrimination and bias, data privacy, medical liability, informed consent, intellectual property. Didn't matter what the application was, one of these issues arose. and underpinning those with these ethical dilemmas. And so we also explored in the book, or I should say the authors, it's an edited volume. So we had several authors who wrote about the ethical perspectives, and they looked at both secular and religious perspectives. Now, we captured in the book Islam and Christianity as religions, but it's broader than that now. This book was developed at a time when there weren't that many people writing about AI in healthcare, but now you can find broader examinations. So anyway, we have these 6 legal issues, and we don't think the laws as they exist in the hard law category still deal with these issues properly. And a lot of work is going on right now to resolving these in more detail. And I'm part of that work, but it's going to be a bit of a long path until we get to a conclusion of where they end up. But to just briefly know what they are, I'm sure to many of you these will be familiar now, because this is becoming quite well explored, this area, but for some of you maybe not, so I'll go through it anyway. So one of the issues is, one of the issues to do with data. Data, it actually means 3 different things. We always hear about data, but it refers to 3 different things if we break it down. The first one is data that's used to train AI systems and the concerns about that data being biased. So AI systems have been developed on data from certain subpopulations of patients in one state, in America, for example, and then used in the care of patients from a different demographic in another state, and has been found that those systems haven't been very useful. So the question in this area is, what do we do legally to ensure that what is used to design these AI algorithms, the data that's used is fair, is based on a representative data set that's important, that's useful for the actual patient population that the AI system is applied on. The second issue with data is privacy. So this is kind of self-explanatory. What are the privacy issues that go into the processing of your data when it's used in an AI system, and in the design of an AI system? And then the final data issue is data security. So what are the concerns we have about the security of data, for example, from hacking or people accessing that data who shouldn't be accessing that data? And we have a chapter in the book, for example, on cybersecurity. I wrote a chapter, co-authored a chapter on the use of blockchain to enhance security in this space. But these are kind of 3 separate issues, and we need to think about the solutions to these legally in all of these areas, and work is going into these. Probably the most work has gone so far into like examinations of data protection laws, like the GDPR, and case law in this area is starting to arise. Like, you have a right to an explanation for an automated decision under the GDPR. What does that mean when AI is used in your care? And how does that conflict with other rights like IP? So I'll mention intellectual property now, because even if we wanted to reveal data about an AI system used in healthcare, that data can be behind a wall of IP, intellectual property protections, and the companies, the developers that design these systems might be able to argue, well, this is protected information, and we don't have to share it with regulators, but the regulators want this information. So what the courts are saying now, in the EU at least, is this is about balancing rights. So on the one hand, for example, the data protection laws, you have a right to an explanation from an algorithm that's being used on you. But on the other hand, companies or developers also have a right to have their data protected. So it will depend on the case that comes before the court, and the court will have to balance these competing rights. And it's quite an interesting area of case law. I think we're going to see more development on down the line. So again, it's very fresh. The case I mentioned there on balancing rights out of the EU only came about within the last few weeks. The other 2 issues on the slide there, medical liability and informed consent. So medical liability, what happens if something goes wrong, and who is responsible? And there are 3 potential parties that are responsible, legally speaking. We've got the doctor, we've got the hospital, and we've got the developer. At the moment, developer liability isn't really the main pathway through which we're seeing much legal development, but some people expect there will be a lot coming down the pathway of developer liability, probably through medical device regulations, but there's still quite a gap there. The other two then, the focus on the doctor and the hospital, as it stands right now, the law is pretty straightforward. If AI is used in your care and you're harmed, the same laws apply now that applied before. The doctor is responsible, or the hospital is responsible for the harms that occur to you, and AI is seen as a tool. The challenge is what happens in the future if AI sets the standard of care itself. If AI sets the standard of care itself, or hospitals require that doctors follow the recommendations of AI, then we're probably going to have to change what legal doctrine says about the standard of care to ensure that doctors either have a defense to the use of AI in their care where something goes wrong, or we simply don't hold doctors liable where they rely on an AI recommendation because they're required to. We're not there yet, but the law might need to change to account for those realities in the future. Some have even looked in the liability front at, well, should we just hold hospitals responsible in the future? Because many hospitals now are actually developing AI systems internally for use in their hospital networks quite broadly. There are some hospitals that as soon as you enter into the door, AI cameras are tracking you, or AI is used in triage or in clinical decision support, and you can't avoid it. So do we just hold the hospitals responsible as a practical matter, since they're developing these systems? And so that area of law is called enterprise liability. And there's also some work going on in that area about whether we should just hold hospitals responsible. And a final complication is, what is the relationship between the doctor and the hospital? So in some cases, it depends on the country. In some cases, a doctor is an employee of a hospital. In other cases, a doctor is an agent of a hospital. So if a doctor is an employee of a hospital, there's already law in this area, vicarious liability is called, which says that the doctor is responsible, the hospital is responsible for their employees' actions that were conducted in the course of employment. But where the doctor is an agent of a hospital, those same rules might not apply. So it can get quite complicated. There's these different pathways for liability, and we're still trying to figure out these areas. It won't surprise me if AI will start to set the standard, it will start to set this standard of care in some areas, or that the hospital will require doctors in some areas to follow AI. So, for example, in radiology, it's proven that AI is more effective than doctors in many instances. And we may find, at least in some areas of where clinical care is given, that the doctors may be required to defer to the output of the AI system over and above their judgment. We're not there yet, but it could happen. Final issue there on the slide I've highlighted is informed consent. And consent actually means two things. So one of them is, does the patient consent to the use of AI in their care? Or does the patient consent to the use of their data being used in AI? That's a slightly different thing to informed consent. Informed consent is, does the patient have enough information about their care to be able to make an informed decision? So on that point, on informed consent, the challenge legally is, if one of the core principles in bioethics and in medical law is that you must be able to make an informed decision about your care. You should be able to ask the doctor, why are you making this decision about my care? And the doctor should be able to answer it. And based on that process, you should be able to then be able to make an affirmative decision or not about whether to continue with that care or not. And the challenge with AI is, if it's being used in that context at the point of care, and the doctor can't really explain why AI is making the decision that it's making, because it's very hard for AI to explain why it's making its decisions and it hallucinates, do you really have informed consent? And I think there's quite a big debate going on here right now. I've been to conferences where there's been quite a bit of disagreement about whether informed consent doctrines need to be altered. I think they do, personally. I think it changes things, and at least in some contexts. Now, in the other context, which is just consent generally, the question of whether a patient consents to the use of AI in their care is also a complicated one. An analysis of this by my co-editor of the book, Glenn Cohen, who also wrote a chapter in the book on informed consent, I highly recommend you read. has found that in the United States, at least, it might not actually be a requirement for a doctor to inform you that AI is being used in your care, and therefore you wouldn't need to consent to its use. In the EU, and some of the studies I've seen coming out of the EU, the answer is a bit different. People are saying that no, a patient must know about the use of AI in their care, and they must consent to its use. So there's actually a lack of clarity in this area about what is where the law actually stands. And I think there's going to be some work to be done in this area too, moving forward. So these are your core legal issues. There are other issues that cross over these 6 underlying themes. And underlying these themes themselves are ethical issues. So I'll just give an example. And ethics plays a bigger role or a lesser role, legally speaking, depending on the country you're in. So the country I'm based in, Qatar, it's quite interesting because Islamic bioethics plays quite a big role in the formation of laws here. And so when the Ministry of Public Health is forming any law in the medical realm, they will explore with Islamic bioethics experts like Professor Muhammad Ghali, who's in my college, who wrote the chapter in the book on Islamic bioethics. They'll look to see whether those laws are compliant with Islamic bioethical principles when developing them. So it can actually have quite intrinsic effect on the formation of law. I'd say that probably has a, it really depends on the country and the context, the extent to which that's significant. But anyway, those themes also play out too. Now, what's been happening so far then around the world is not enough on these legal issues and more on the development of medical device regulations. And we've seen this development in the US through the FDA. In the European Union, I would say the Artificial Intelligence Act is kind of a bolt-on to the medical device regulations there. You still have to comply with medical device regulations plus the AI Act's requirements, but they don't add much, I would say, in terms of like the actual core healthcare law legal protections we need to worry about. China also, there are the developments in the medical device regulations there. The UK is working on them. There's been some good work in Saudi Arabia on this, Singapore, South Korea. I wrote an article in particular on Saudi Arabia, I think is taking the lead a bit in this space. The problem I have is, though, is that while lots of countries are advancing their medical device regulations, that does not cover every type of AI that's used in medical or clinical practice. It's useful, it's important, but it's one piece of the puzzle. And a lot of my recent work is trying to conceptualize, broadly speaking, what is the life cycle of AI? What is the life cycle for it? And so we need to think about AI in the very beginning stages when we're researching and developing it, and what are the rules there? And so far, there are not many rules. We've developed some in Qatar that I led a grant. I can speak about that in a moment. What are the rules in the middle stage when you've actually got some sort of medical AI system and you want to bring it to the market? Yes, there are medical device regulations, but again, they don't cover the whole scope of uses of AI in medical practice. So I don't think it's enough. You need a little bit more. And then what about in the back end when you're using AI in clinical practice and the doctor's using it in practice or the hospital's using it in their hospital network? What are the rules there? And so medical device regulations are what are developing around the world. They don't account for that life cycle sufficiently, in my opinion. And that's where the work is to be done. I'm now on a working group for the World Health Organization who's looking at these issues, and we're trying to determine what is the best path forward for this. I believe you need rules in all stages. You need rules when you're researching and developing AI systems for the use in eventually in practice. But you need rules at the R&D stage. You need rules at the approval stage, and you need some rules at the stage of the use of AI in clinical practice itself to capture these legal issues that we identified and other cross-cutting themes, which are important. So there's a lot of work to be done there, in my opinion. Just a note also on, there's a lot that's been, of course, spoken about ChatGPT and generative AI systems. I don't think they really change much about the underlying legal issues that we have to deal with. The same legal issues remain. I would say, though, and I've written about this in another article on, it's on the use of AI in mental health. And I've been quite concerned that ChatGPT has been doctors have been experimenting with its use on their patients, which is quite unethical. They should only use approved AI systems that have gone through the right sort of research and development and have had approvals for that specific use. But some doctors haven't followed that. And we've seen, for example, in Australia, regulators come out and ban doctors from the use of ChatGPT because they saw concerning uses. And this is not an insignificant concern. I do see doctors at medical conferences raise their hand when I ask them if they're using ChatGPT in practice. So there's a lot to be said about that, but legally, I don't think it changes the core legal issues. So there's so much more I can say, but I might wrap up here so that we have time for Q&A, so that you, I'm not sure what questions you might have. But I'm looking at this quite broadly as the editor of this, the co-editor of this book on research, the Research Handbook on Health, AI, and the Law. I'm concerned about AI and the legal and ethical issues across its whole life cycle, and the use of AI in specific subfields of medicine, and what the rules are that we need in those areas. So I'm also recently written about whether we might need an AI Bill of Rights for patients that might be used at the point of care to ensure that they are aware of their rights. So I'll stop there, open to questions, and thank you all so much for listening. If you feel free to connect with me on LinkedIn. I'm always posting updates there on publications, on work we're doing in this space. Feel free to drop me a question. I try to answer all the questions I get. So thank you all for listening. Very grateful.
Thank you, Dr. Barry, for this very, very helpful and then exposition, especially on the legal aspects. I think that's very important, because looking AI from the point of view of innovation, like innovation, yes, like we need innovations in place, but then of course, like I could probably connect with this analogy of a shoe, like it can't be too loose or too light. Like, so we need to have regulations at the same time that it cannot be too tight that it can stymie the innovation. And then at the same time, it cannot be too loose that, we actually lose the sensitivity part of it, especially with respect to the patient privacy, confidentiality, or the security or the sanctity behind what is health data primarily being used. I think like we have just about 15 minutes to close. So maybe I think we should take the questions from the audience at this point of time for both the speakers.
Should I read out a couple of the questions which were asked initially, maybe, Jay, and then
Yes,
point
maybe.
them towards some of the speakers? I know, Anita, there were a few questions for you. I have a couple for Barry and Anita too, but I'll come to myself last. Anita, it seems Sunanda has asked, sometimes can we see, because of lack of efficient physicians, patients suffer a lot? Then how and in what way can AI help in these circumstances? So would you like to respond to each individually? Yeah. So
We could, yeah. Thanks. I'm sure, even Barry will have something to say on this. I do think that there is